Assalamu alaikum. We welcome you all in this afternoon session, targeting a very special subject, which is mechanical ventilation in the OR, how to protect your patient, how to ventilate well, not only just ventilate. It's my pleasure to welcome Professor Mert Sentործk from Istanbul University. He is an expert in adult thoracic anesthesia, and he will talk to us about protective ventilation in anesthesia. Please.
Thank you very much for the invitation. It's my second time in Cairo and fourth time in Egypt, and I'm very happy to be here again in Cairo. My lecture for the next minutes will be the protective ventilation in anesthesia, okay? And if we are talking about protection, this is the agenda of my topic. First of all, I will tell you something about what do I have to protect? Do I really have to protect? And if yes, how? And whether this protection would be really successful is another question. And at the end of my lecture, I will tell something about the requirements for a successful lung protection. First of all, what do I have to protect? We have to protect during mechanical ventilation two different things about the lung. First of all, we have to protect, we have to maintain the functions of the lung, which is oxygenation and gas exchange. And we have to protect the lung itself too. Unfortunately, it can be the case, and it is the case, it is often the case, that the ways to protect and to maintain the functions of the lung and the ways to protect the lung itself can interfere to each other. I mean, if you do something to protect the functions of the lung, it can be the case that you can harm the lung itself and vice versa. So, what do I have to protect? We have the experience also as anesthesiologists, the experience from the treatment of ARDS in the ICU. If we have started the mechanical ventilation in the treatment of the ARDS, the only target was to improve the oxygenation of the patient. And therefore, the mechanical ventilation has been invented. But afterwards, people have seen, our teachers have seen, that via this mechanical ventilation with the bad ventilators, insufficient ventilators, we have had a ventilator-associated or ventilator-induced lung injury. This was because of four different types of trauma: barotrauma, volutrauma, atelectotrauma, and as a consequence of these three traumas, we have also a biotrauma. And at the last result, we have invented and intended to improve the oxygenation, but the last result was just the opposite. We have harmed the lung, and we have also changed the functions of the lung. So there was a decrease in of the oxygenation. So this was a wrong solution. If for a successful treatment of ARDS, we have to find some way to increase the oxygenation and also a prevention of ventilator-associated lung injury. And the solution for this question was not only the mechanical ventilation, it was a protective ventilation. And protective ventilation is a bundle of several mechanisms with low tidal volume, some PEEP, some decrease in FiO2, some recruitment maneuvers, and maybe also some permissive, even therapeutic hypocapnia. And therefore, we need some reliable, safe ventilators to maintain the protective ventilation. What is the case in anesthesia? As the chairman said, I'm rather a thoracic anesthetist, and we have seen it especially during one lung ventilation. In the one lung ventilation, if we apply the whole tidal volume to the ventilated lung, here you can see it, you would have a volutrauma. With this volutrauma, you would have also a barotrauma, And if you don't apply some PEEP, you can have also some atelectotrauma too. And what do I have to protect? What is the difference between spontaneous breathing and mechanical ventilation? We all know that there are some changes between mechanical ventilation and spontaneous breathing. If I breathe spontaneously, you can see that the main part of the breathing is here, the bottom side, the dependent parts of the lung. And this is good so, because the perfusion of the lung is also better than the upper parts of the lung. And therefore, we have a good match of ventilation and perfusion. But how is the case in the mechanical ventilation? You see here, there's already an atelectatic area. You don't see, okay, but here at the bottom. And as you can see, the ventilation is diverted to the non-dependent areas. This would cause here already some atelectatic damage. We have here the more perfusion than here, but the ventilation is increasing here and not here. This is a ventilation perfusion mismatch. So during the mechanical ventilation, we have a mismatch of ventilation perfusion and also an increase in the atelectatic regions. So what can we do? What was the other mistake that we have had? Previously, we have two types of ventilators. In the ICU, we have had really ventilators because the main aim of these devices in the ICU was the mechanical ventilation. In the OR, there were something, the things were something different, the devices, the apparatus. There were anesthesia machines because the main target of that devices, apparatus, was to maintain the anesthesia. And mechanical ventilation in the OR was not that important, was not as important as the mechanical ventilation in the ICU. Was that right? It was not so right. Therefore, this is an ancient classification. Because it was taught, I'm doing anesthesia since 1990, so quite a lot, almost a life. And during my beginning years, it was the case that the guidelines in that times of the mechanical ventilation during anesthesia was a high tidal volume. If possible, ZEEP, so no PEEP, very often aspiration of the secretions, and don't afraid of increasing the FiO2. This was something that belongs to the age of dinosaurs. These guidelines are, you have to know, we all have to know, these guidelines is not valid anymore. So why do I have to protect and what do I have to do? As I said before, let us make an analogy. There's a difference between spontaneous ventilation and mechanical ventilation. Spontaneous ventilation is something like a talk face to face. And if I would talk with you face to face, my voice would clap something like this. But if I have to talk with all the people here, consider that you are the alveoli and I'm the mechanical ventilator. I had to change something during mechanical ventilation. I cannot talk to you all as I would talk face to face with someone. This is the main difference. And therefore, mechanical ventilation is unphysiologic, as it's a massive destructive weapon of intensive care. And there we can see it also here. Again, a picture from thoracic anesthesia. One lung is ventilated, so that lung belongs to us, and the other lung is operated. It was a lobectomy. And please tell me which lung was the lung of the anesthesia and which lung was the lung of the surgery. For we are here all anesthetists, we can confess that unfortunately this lung was mechanically ventilated by us and this lung was surgical. Again, here the lung is the atelectatic and is the anesthetic lung and this is the operated lung. Unfortunately, we are, as the anesthesiologists, the guilty ones. So what do I do? The guidelines of the dinosaurs was to increase the FiO2. But this is also not a good idea because nitrogen keeps the alveoli open. It has been shown, it was a study, I think 22 years old, from 95, that even with the 100% of oxygen during the pre-oxygenation period, in 2 minutes, you can create a large area. Just after intubation, you can have a large area of atelectasis here. Even this 2-3 minutes of 100% oxygen can create some atelectasis too. So this was also wrong. So how can I protect now? First of all, a decrease in FiO2. There are new different methods of having 100% oxygen, having lower percentages of oxygen instead of 100% of oxygen. Then the bundle of protective ventilation, which has 3 components: low tidal volume, PEEP, and recruitment maneuver. I will talk about recruitment maneuver in my next lecture, therefore I skip it, but we will talk about other things. We can change the agents, which is another question in this topic, and low flow anesthesia. This is also a very important thing. In my youth, during my residency period, we have had flows like 6 liters, 8 liters, 10 liters per minute. Even 4 liters per minute was in that times a low flow. Nowadays, if my resident would apply some 4 liters per minute, I will say, are you crazy? Do you want to harm us? Because it's hazardous for the patient, it's hazardous for us too. And therefore, please, low flow anesthesia is actually a part of protective ventilation. There are still a lot of studies and recommendations showing that a higher FiO2 is still beneficial. Very recently, we all know there has been the recommendation of World Health Organization, WHO, which has been published in Lancet, recommending to use of 80% of oxygen during the perioperative period. It has been a big debate, and the experts of anesthesia have said that this recommendation is biased and it's not concrete. I'm also the editor of the Turkish Journal, and in this issue you will have a forum about it, and I will recommend you to read it. How about, so regarding the FiO2, we have to personalize, we have to tailorize also the level of the FiO2. First of all, we have to increase the FiO2 to maintain a good tissue oxygenation. But we have to decrease the FiO2 to protect, to prevent a lung injury. So we have to find a level within the safety margin. And we have to do it, all of this, also by permitting a low flow anesthesia. Because during the low flow anesthesia, if you have an unreliable anesthesia machine, the low flow anesthesia can also lead to a decreased supply of oxygen by the anesthesia machine. Therefore, we have a triple challenge regarding the FiO2. How about PEEP? The question with the mechanical ventilation is that the FRC drops below the closing capacity. Normally, the FRC is somewhere above the closing capacity, somewhere here. But after the induction of anesthesia, the FRC drops below the closing capacity. And therefore, I have to do something. Because every time I breathe, here my alveoli collapse. This is only the area that I can ventilate my patient. And at the end of the experiment, the alveoli collapse too. So I have a cyclic opening and reopening, closing of the alveoli. This is actually the atelectotrauma, and therefore it can be very hazardous to the patient. Formerly, the solution was to increase the tidal volume. Now I have a larger area of ventilation. I can have, with larger tidal volumes, a better gas exchange. But it is not a solution for the cyclic opening and reopening of the... Is something with my voice? Sorry. Okay. Cyclic opening and reopening of the alveoli. Now what can I do? Instead of increasing the tidal volume, I can apply some PEEP. If I apply some PEEP, I can bring my FRC above the closing capacity. With the PEEP, as you can see, there is no cyclic opening and closing of the alveoli. The PEEP works for it. Again, if we do the analogy again, it was a difference between the spontaneous breathing and mechanical ventilation. During spontaneous breathing, it is like a talk face-to-face, and my voice will something like this. But if I use this voice during my lecture too, during mechanical ventilation, everybody would sleep here. This would mean everybody would have some atelectasis. To prevent the atelectasis, to prevent that to sleep, I have to give some pressure to my tone. And with this pressure, with this PEEP, I hope that my audience, the alveoli here, would not sleep. Therefore, some PEEP during mechanical ventilation is something like my voice during my lecture, and this would keep the alveoli open. There's something about recruitment, we will come there too. But what happens during PEEP application? You see here, with PEEP, the gas exchange generally is getting better. But there are some patients, look at there, some 4 or 5 patients in that study, in whom the oxygenation gets worse. How can this be the case? It was again the paleontologic guideline, where you can see this was the ICU book, the famous ICU book from Marino, that the PEEP can be harmful during mechanical ventilation in healthy lungs. And this is not very appropriate, I think. But we have to find, again, like it was the case in the FiO2, also with the PEEP, we have to find the best PEEP which can be good for the patient. The best PEEP is the pressure level which is very close as can be, to this lower inflection point, lip, lower inflection point there. If you go with your PEEP too much above the lower inflection point, this PEEP will be harmful for your patient. So you have to find some PEEP level like B here or right here to have the best. And in every patient, the lower inflection point will be somewhere here, somewhere different. Therefore, in each and every patient, we have to make a PEEP titration. And this would lead to a protective ventilation. Otherwise, PEEP itself can increase, but also can decrease the oxygenation. PEEP can be good for the lung protection, but in some patients, it can be also bad for the patient. It is you, it is we, it is me, who would find the best PEEP for the patient. This is a famous study from Amato of 2 years ago, showing that it is actually the driving pressure, which is the important one, which would prevent the lung injury. As I said before, I will come to recruitment maneuver in my third talk, but we had to keep in mind the protective ventilation is a bundle of 3 different components. And this is the first study from 2013, showing that the bundle of the protective ventilation, you can see it downwards, a low tidal volume, 10 PEEP, and recruitment maneuver is associated not only with a decreased release of the inflammatory mediators, etc., not only with laboratory parameters, but also with clinical findings, where you can see that it is associated with a lower postoperative infection, with a better postoperative saturation, and with better radiological findings. Again, in the study of Amato, you can see also that the protective ventilation of this bundle has led to a better survival, to a better Kaplan-Meier curve after the operation. But unfortunately, science has always some question marks in it. And some 2 years ago, the Provallo trial, I was also a part of this trial, has been published showing that high PEEP and low PEEP with and without recruitment maneuver was not associated with a change in the percentage of the postoperative complications. It was very interesting, but probably here it is the main problem of the study, that the high PEEP in terms of protective ventilation group has been applied only with a fixed PEEP, and therefore it's not good, it's not reliable for the general rules of PEEP titration. Now we are doing a study, PROTOR study, throughout Europe, not only in Europe, throughout the world, and I would, I'm the primary investigator, and I would invite you also to join this study. How about the inhalational agents? There's another question about it. This was a study showing that the inhalational anesthetics were associated with a lower release of inflammatory mediators, and therefore with a better clinical finding, at least after thoracic surgery. And this has been shown also in another study from Switzerland too. However, another group in Switzerland has shown that sevoflurane versus propofol was very similar regarding the postoperative effects. Again, the group has shown that both agents were very similar also in postoperative complications too. Very recently, last year, the same group has also shown that also during lung surgery, there were no differences between the use of sevoflurane and propofol. So how about the conclusions? First of all, we have to know, first of all, that we have to use some protective ventilation, because mechanical ventilation, even for the healthy lungs, is unphysiologic. And therefore, we have to adapt to the alveoli of each and every patient. And we have to tailorize, we have to personalize our mechanical ventilation strategy. We have to consider a low FiO2 as possible. We have to keep in mind that protective ventilation is a bundle of 3 components of low tidal volume, PEEP, and recruitment maneuver. Do not forget to apply some low flow anesthesia. The question about the agent, inhalational or intravenous agent, is still valid. The second conclusion is about the ventilators. We have to have reliable ventilators, anesthesia machines, also in the operating room, as we have them in the ICU. We have to have these ventilators. The machine in the operating room must be a ventilator to be reliable also both in healthy and sick lungs. It has to be an anesthesia machine reliable for low flow anesthesia and reliable, which permits a reliable decrease in anesthetic consumption. And it has to be a monitor to show us that we can protect both the lung and also the functions of the lung. Therefore, we have to have a good anesthesia machine in the operating room too. That was my first lecture. The second one will be the second part of the lecture too. I thank you very much, Shukran, for your patience.
Any question?
Professor Mert, thank you very much for this very elaborative talk. You mentioned more than once the low flow anesthesia. Would you elaborate on how low flow anesthesia is protective to the lungs?
Actually, we are now doing a study about it. It's not very easy to show the effects of low flow anesthesia directly in the protection of the lung. This is a general knowledge, and I know this is not evidence-based, but we know that the higher the flow of the gas, the higher the damage in the mucociliary activity and clearance of the secretions, etc. But I have to say, it is not evidence-based. It is very old knowledge, but yes, we all think that this should be also the case, because the gases that we have, they call it medical gases, but they are not medical actually. They are, first of all, cold, and they are dry. What we breathe is rather hot, okay, let's say not hot, but warm, physiologically warm, and also wet. And the more the flow, the more wet, the wetter, and the colder. And therefore, there are also some studies showing that the clearance of the mucociliary activity is decreased really, but this, you cannot say that this is the evidence. They have done it. There's a Turkish study from another group and an Italian study. They have shown the flow of glucose that they have dropped on the trachea, and they could show that the movement of the drop of the glucose was diminished with the high flow anesthesia.
Thank you very much.
Thank you for the question. That was also a slide actually, but I have skipped it. I'm a fan of the pressure controlled ventilation. This was my first international publication actually, but it has been shown afterwards that there are no concrete differences between pressure controlled and volume controlled ventilation. I still use pressure controlled ventilation. I'm giving you a subjective answer as an advertisement of the pressure controlled ventilation. With the pressure controlled ventilation, you can have a better differentiation of the air, because you keep the pressure constant, and if you have alveoli with different compliances, the share of the air, of the gas, would be more homogeneous. For a homogeneous ventilation, it has been at least shown in IRDS patients, but in healthy lungs, we still need some evidence about it. Probably, the newer anesthesia machines are capable to supply also this homogeneous distribution of ventilation, also with the volume controlled ventilation. What they have is something like the name changes from company to company, but this is at least the same thing. There's a pressure regulated volume control. So it's a volume control. You set the volume, but the pressure is constant. So you have a decelerating flow, like it is the case in the volume control. And if you have a decelerating flow, you can consider that the distribution of ventilation is more homogeneous. It's like, I think this type of ventilation would be the optimal one.
How do you adjust the ventilatory setting in your clinical practice? The ventilatory setting in your daily practice, okay. How you tailor your protective lung strategy? Did you do a routine PV curve to show the lower inflection point, or how to adjust the PEEP, for example?
Okay, well, as I said before, I'm working in thoracic anesthesia, but both in thoracic anesthesia and also in general surgery, we don't start anymore with 100% of oxygen during pro-oxygenation. This for sure. Rather some CPAP and some 0.7% of oxygen, that would be very beneficial, I think. Afterwards, if we have a general surgery, in abdominal general surgery, pressure-controlled ventilation cannot be a good idea, because every time the pressure changes in the abdomen, the ventilation, the tidal volume changes too. So it can lead to hyper and hypoventilation. And I'm working in an educational hospital in faculty. You cannot trust your residents that much that he or she would follow the changes in the ventilation. Therefore, a volume-controlled ventilation is a good idea. We always give some PEEP. Actually, it would be a good idea to make a PEEP titration in every patient, and then apply this PEEP to the patient. This has been shown in a study from Spain, and there was a very significant difference between the constant PEEP of PEEP and the tailorized PEEP. And therefore, tailorizing the PEEP, personalizing the PEEP is a good idea, but it's not very easy, and we don't have the ventilators for this time. But we use recruitment maneuver. In thoracic anesthesia, I'm using the recruitment maneuver very often if I don't have any contraindication for this one. And low tidal volume for sure, 6 ml per kilogram. Thank you.
Thank you very much for this elegant presentation.